just we'll just start in a minute. Okay, so we'll go. Okay, so we'll start. So, good evening, everyone. Myself, Dr. Rijul Agarwal. I'm the orthodontic faculty at DAMS. So, as part of our daily live sessions on YouTube, we are today is the day for the subject of orthodontics. So, we'll be meeting every Thursday to take up some new topics to discuss. So any of you have any specific topic which you want to have a live discussion on, or it's not clear, we are open to suggestions as well. Okay, so the topic which I'm taking today is anchorage. So it's the most, most important topic in considering the orthodontic point of view, whether you pursue or post graduation in orthodontics, or anyone, your seniors who are doing PG in orthodontics, most of them would talk about this only one word, that is anchorage, and how to burn it, how to preserve it. That's the whole interplay, and that's the whole biomechanics science which is based. So what is anchorage first of all? Okay, so as we know that anchorage is basically what it is. It is resistance to any kind of unwanted tooth movement. So in orthodontics, what we do is we apply forces so as to achieve a desired tooth movement. So at the same time, we know from Newton's laws of motion that for every desired force or desired action, there is an equal and opposite reaction. Okay, so for every desired force which we induce, there will be an undesirable or undesirable movement which will occur on some other side, some other tooth. Okay, which will be an undesirable force. Okay, so what is the aim? So the aim of our treatment is to have the desirable force, that is the maximum tooth movement which we desire, and minimize the undesirable side effects which is occurring on the other tooth. So if we consider an example, so I'll be taking this example throughout my lecture today of an extraction case in which we extract first premolars and we retract the anteriors in that empty space or the extraction space. Okay, this is the most common type of orthodontic treatment most of you would have heard or would have undergone themselves when we extract teeth and retract the anterior teeth into that empty space. So in this image, the 4 is extracted and we are retracting the anterior teeth with an active force. So what will happen? As I've said, for every desirable force or every desirable tooth movement, there is an equal and opposite reaction. So what will be the reaction? The reaction will be, what we desire is we want to retract the anterior teeth into that empty space. And what will be the undesirable force? The posterior teeth, that is the second premolar and the first molar, will retract or also move into that empty space. Okay, so supposedly there is 8 mm of space, and what we wanted is to correct or retract the anterior teeth to correct the proclination, and at the same time the posterior teeth will also move into that empty space, thereby minimizing or will minimizing the space closure by the anterior and minimizing the correction of proclusion. Okay, so therefore in anchorage preservation, or the topic which anchorage which we are going to discuss today, is to concentrate these forces needed to produce tooth movement where it is desired and dissipate the reaction forces over as many teeth as possible, so as to keep the pressure in the PDL of the anchored teeth as low as possible. So these undesirable tooth movement, that is the movement of the second premolar and the molar, if we want to minimize them, what we need to do is to dissipate this reactive forces over many teeth, so that this undesirable movement decreases. Okay, or we can minimize that undesirable movement as much as possible. Okay, so how do we do that? We'll discuss it. First, we'll discuss and understand two of the very important graphs which can be part of your exams as well. So first graph is from the biology of tooth movement, which depicts the amount of tooth movement which occur with the amount of force or pressure which we exert. So what happens is, in the initial phase, after a certain lag period, as we know from biology of tooth movement, when we apply force, the tooth does not directly start to move. There is a lag movement due to the buildup of hyalinized tissue. When it is removed, this lag tissue is removed or hyalinized tissue is removed, the tooth movement starts. So the teeth initially behaves as if the orthodontic movement is proportional to the magnitude of pressure which is applied. So till this point, the pressure and the amount of tooth movement is directly proportional. Okay, that means jitna force or jitna pressure we are applying, the tooth will move that much only. So what happens when this point is reached? So when this point is reached, is jack screw intermittent or interrupted forces? We'll come to that. Okay, we'll come to that, not to worry. Interrupted, intermittent forces, we'll discuss it. So for right now, just concentrate on this. If I forget in the end, you can always tag me, I'll tell you, and you can ask me. Okay, for not just concentrate on this topic, because it's very important. If you miss it out, in the end you won't be able to understand. And anchorage is mostly understanding है and theory कम है, रटने वाला कम है and understanding point ज़्यादा है. Okay, so when this point is reached, okay, the amount of good evening tooth movement, what happens? It becomes less dependent on the magnitude of pressure which is applied. So after this point, jitna pressure or the amount of pressure we are increasing, the amount of tooth movement remains the same. Supposedly it is moving at 5 mm per month, so it will remain the same as 5 mm. Okay, so what does it mean? It means for every tooth movement to occur, there is an optimal force level which should be reached, or the first, or you can say the threshold. What do you mean by threshold? Threshold is the minimum amount of force which should be applied for so as to have an optimal or a certain amount of tooth movement to occur. Beyond that threshold or beyond that optimal force, if we increase the pressure or increase the force, the amount of tooth movement remains the same. It does not increase much. Okay, so how is this concept important or linked to our topic of anchorage? Okay, so how is it linked? What I mean to say is, the pressure or the force on the active unit should be, if we keep it above or the at the optimal level, and on the reactive movement tooth or the tooth which we do not want to move, we keep the force level below the optimal level. So what will happen? The active unit will move according to the amount of pressure which is applied, and the desirable tooth movement will occur. But जो reactive movement tooth है, or the tooth which we where we do not want the movement, that won't move, and that is what we require in our orthodontic treatment. Okay, so that is why this graph is very important for you to understand. How do we do it? I'll tell you in the next upcoming few slides. Okay, so what happened? First, let's come back to this graph only. What happened? If we apply force greater than that of optimal threshold or threshold force, it will be, first of all, as I've told you, equally effective in orthodontic tooth movement. Next, it can cause trauma to the teeth, and third, it is also stressful to anchorage. So what do I mean by saying that it is stressful to anchorage? So for us to understand this last point, that is, it is stressful to anchorage, means it causes stress on the anchorage unit, we need to come to the next graph. Okay, I hope I'm clear until now. If anyone has any doubt in the previous graph, just ask, because iske baad wala then you won't be able to understand. Okay, so moving ahead, so as I told you, now instead of denoting them as active and reactive movement, I'll denote them as A and M. A will be the, A means anchor unit, M will the movement unit or movement teeth or anchor teeth. So as I have told you before as well, the aim of orthodontic therapy is to keep the force or pressure on the anchor unit below the optimal level so as to have a desirable movement. So in the last point, as I said, that if we increase the force beyond the threshold, it will be stressful to anchorage. So इसको हम similar graph से समझते हैं. यहाँ तक तो हमारा till here our desirable movement was occurring. As we increase the pressure, what happens? The force which is acting on the M and the A unit, okay, increases. So what it does, it lead to? It leads to the similar kind of, like as I said, 5 mm, an arbitrary magnitude which I said, the same amount of movement will start to occur. And if we further increase the forces, what will happen? The M unit, the amount of tooth movement will decrease, and the anchor unit will start to move more. That is, the posterior teeth will start to move more as compared to the anterior teeth. That is what I mean by it is stressful to anchorage. That means the amount of force which is applied is very, very important for us to have a desirable amount of movement. So differential response to pressure, so that heavier pressure produces more tooth movement than lighter pressure would make it possible to move some teeth more than would make it possible to move some teeth more than others. So that is what is the aim of anchorage and anchorage therapy is. So this is the basic and the most important concept behind the anchorage principles in orthodontics. Okay, if you are clear with this, you will be very easily be able to understand the upcoming things, the classification, the methods, how do we do it. I hope I am clear until now, then I'll move ahead. Okay, so coming to the classification of anchorage system, first classification was given by Salzman. It is according to the manner of force application, or how do we apply the forces. So it is divided into three types, that is simple, stationary and reciprocal. सिंपल स्टेशनरी एंड रेसिप्रोकल में देयर इज अ वन एक वर्ड का डिफरेंस है जिसमें उसकी डेफिनेशन एंड ऑल चेंज हो जाती है. सो दिस वर्ड बिकम्स वेरी वेरी इंपॉर्टेंट इन ऑन INI एग्जाम वेयर दे गिव यू इन द फॉर्म असर्शन एंड रीजनिंग, चाहे एक वर्ड बदलते ही रीजनिंग गलत या सही कहना करे. सो व्हाट इज सिंपल एंकरेज? Simple anchorage means that is resistance to tipping. Simple anchorage means resistance to tipping. Example seen in removable appliances. So all of you must have designed or given a Hawley's appliance in which we compress the labial bow to tip or retract the anterior teeth. Okay, so what does this labial bow exert? It exerts a force on the anterior teeth so that they tip lingually and close the space and retract. Okay, so what happens, as I have told you, for every desirable action that is exerted on the anterior teeth, there will be an undesirable reaction on the posterior teeth. So the posterior teeth can also tip in the forward direction, that is they can also mesially tip. So how are they prevented from mesially tipping? It is through the acrylic plate which embeds inside the grooves between the teeth. Okay, so resistance to tipping as seen in the removable appliances. Next is stationary anchorage. Stationary anchorage is resistance to bodily movement of anchor unit. Okay, the example which I gave you just now, extraction case in which we are retracting the anterior teeth, we apply the force. The posterior teeth also have a tendency to mesialize. So while we are distalizing the anterior teeth to correct the proclination, the posterior teeth also have the tendency. So here we have to have a stationary anchorage so as to prevent their mesialization. How do we do that? I'll tell you. How do we apply anchorage? Okay, another very very important example is use of in the Beck's technique, in which we tip the anterior teeth. In the Beck's technique is light wire differential force technique. So Beck's technique is example of stationary anchorage, in which we tip the anterior teeth and resistance to the movement of posterior teeth. So what happens in Beck's techniques, an edgewise. So if you know from evolution of edge orthodontic appliance what is Beck's and what is edgewise. In Beck's technique, what we do is we tip the teeth and then upright it. Tip, upright, that's how we move. Whereas in edgewise we bodily retract them. So that's why, so the what Raymond Begg used to tell is, so that by tipping and uprighting he was utilizing or putting more or less stress on the posterior teeth so as to cause less anchorage loss or less movement of them. Okay, so that's why stationary anchorage is an example of Beck's technique, in which just we tip the anterior teeth and then upright, tip, upright, so as to have a bodily tooth movement. And lastly reciprocal anchorage. इसमें मैंने एक word बहुत highlight किया, that is equal. That is two or more teeth equal in size moving in opposite direction and pitted against each other by appliances. Example RME. that rapid maxillary expansion. Next, closure of midline diastema with elastics and expansion screws. Okay, so why equal in size is very important? Because I just gave you this example. Here also there is reciprocal movement. The anterior teeth are mesializing, the posterior distalizing, but they are not equal in size. The periodontal surface area of the molars and premolars is much more as compared to the anterior teeth. So they become unequal. That's why this cannot be example of reciprocal anchorage. Okay, so the teeth should be equal in size, that is they should have an equal periodontal surface area for us to classify them into reciprocal anchorage. So I have one question, sir, many implants are stationary. No, many implants are part of cortical anchorage. I'll come to that. See, as I've already told you, many implants, NANS, I'll tell you, these are the examples of through which we gain anchorage. Right now, first understand the topic and what is the concept behind it. Then we will jump to the examples. Okay, because right now आपके exam में beat NEET or INI doesn't ask you just the name. Okay, what is the example of stationary example? Option A, B, C, D. No. Right now they are asking and then going behind the theory and its application as well. It's no longer a direct just MCQ based exam in which you have to just mug up the example and spit it out in the exam. Right now it's an application based exam. That's why we need to understand this theory and concept behind it as well. Okay, so I'll come to mini implants as well in a few minutes. So as I was telling, simple anchorage, and please now don't get confused. That's why I said reciprocal and stationary. Resistance to tipping is the keyword. Resistance to bodily movement is the keyword. Keyword ढूंढना है क्वेश्चन में आंसर करने से पहले हमेशा. Okay, reciprocal, two or more teeth equal in size and moving in opposite direction. अभी last May INI exam, recent exam में they asked you about couple. Okay, जिसमें exact definition they asked you. Okay, and generally students, you know, in my class they ask you, why sir, why are we discussing definitions while it's a MCQ based exam, not a theory exam. Direct pick definition was there and you were asked up to identify the type of tooth movement which is happening. Okay, so moving ahead, simple anchorage. So simple anchorage, when the manner and application of force is such that it tends to change the axial inclination of the tooth or teeth that form the anchorage unit in the plane of space in which the force is applied. Okay, so as I've told you, resistance to tipping of the anchorage unit might be used to retract certain other teeth. So iska example, as I've already, first example I gave you, the anterior retraction using a removable appliance by incorporating a long labial bow and retention clasp. Next example, this is the most common thing which is used by periodontists to correct the anterior crossbite using expansion screw. So what you do is they turn the screw so as to retract or tip the incisor so as to correct the crossbite. So this is an example of simple anchorage, not reciprocal. Wherever you see expansion screw doesn't mean that it's an example of simple anchorage, or sorry, reciprocal. You have to look for the purpose for which this expansion screw is being given. Had this expansion screw been in the midline here, then it would have been an example of reciprocal anchorage. Why? Because equal size teeth are being opened up. Okay, so again, as I'm saying, examples ko blindly mug up nahi karna hai. You need to understand the theory behind it. Just by changing the position of this jack screw from here to midline, the whole concept changes. So this was the example which I just pointed out. Here the expansion screw is in the midline. It is used to expand the upper arch so as to correct the transverse deficiency. Okay, so here it becomes example of reciprocal anchorage. Okay, so two teeth or set of teeth which are moving to an equal extent in the opposite direction. Next example, when we close the midline diastema using an elastomeric chain. This is a very common example जो बहुत पहले के एग्जाम्स में they used to ask. Okay, next, according to the, this was the first classification of salesman. Next is, यहाँ तक कोई doubt है please ask, otherwise I'll move ahead to the next classification system. Next is according to the jaws involved. It can be either intramaxillary, which can be easily understood, that is in the same jaw, and intermaxillary, that is in which involve both the jaws, that is upper and lower. And the best example of this is the Baker's anchorage, which was given by Henry Baker. So this is the intramaxillary anchorage, in which the same side, these two teeth are considered in an anchorage unit, the second premolar and the molar, and the canine is retracted from the same jaw. And intermaxillary is this, that is, this is the example of Baker's anchorage. So the elastic is applied from the lower molar to the upper. So two forces are applied. Vector component, as we all know from our 11th-12th physics, can be resolved into two directions, one this, one this. Okay, another example of Baker's anchorage, intermaxillary anchorage, in which we place a button from the palatal side of upper and buccal side of lower. What has happened? We place an elastic. What happens? The upper teeth go buccally, the lower go lingually, so as to correct the posterior crossbite. Okay, so Baker's anchorage, intermaxillary anchorage का example. Next is to correct the crossbite or scissor bite is an example of intermaxillary. Elastics applied to correct the scissor bite or crossbite is example of intermaxillary anchorage. Next is according to site of anchorage unit used. It can be the intraoral, we have just discussed the examples. Extraoral, example using the headgear and face mask, these are orthopedic appliances. And muscular, which are derived from the action of muscle, example vestibular shields, lip bumpers. Vestibular shield में सबसे common आ जाता है oral screen, lip bumper using a acrylic plate in the lower arch so as to correct the hyperactive mentalis activity. Okay, we have discussed in the myofunctional region. So this is the images of extraoral. This is the headgear, cervical pull headgear. This is the combi pull headgear. This is the image of a lip bumper. Okay, see, this acrylic shield is constructed at a distance away from the lower teeth. So what will happen? The mentalis of the lip will exert pressure on this. It will lead to distalizing, and at the same time the tongue will push these teeth forward to correct the lower arch crowd. Next, according to the number of anchorage units used, it can be single or primary involving only one teeth, compound involving two or more teeth, and reinforce, it means addition of non-anchorage units. So the best example of reinforcing an anchorage is involving the second molars as well. Involving the second molars as well. So let me come back to the previous example, the first which we discussed. So here 5, 6. So as I've told you, if we increase the periodontal surface area, that means we band or place extender wire till the second molar as well. So what will happen? The pedial surface area further increase. That means the force dissipated further increases over the teeth. So what will happen? The force on these teeth remain below the threshold or the optimal force level. So what will happen? The anchor unit or the unit will move less as compared to the anterior unit. So this is a way of reinforcing the anchorage. What are the other ways of reinforcing the anchorage? We can take the help of the muscles, the head and mucosa. So what do you mean by taking the help of muscles or head? That means adding headgear, which takes advantage from the extraoral surface area. Okay, or we can also reinforce the anchorage by involving or connecting the molars from opposite arch as well. by the help of transpalatal arch, translingual arch. What are these? I'll just show you the images. Through a wire component soldered from one molar to another, we are further. So imagine earlier it was just 1, 5 and 6. We connected 5, 6, 7 of one side. Now we connecting the 6 and of the one arch to the other side as well. So the periodontal surface area further increases from earlier 2 to 3 now to 6 teeth. So the force gets dissipated over a very large periodontal surface area, thereby minimizing the tooth movement of these teeth. So reinforced anchorage I have just discussed. Next comes cortical anchorage. So as we know what is cortical bone and cancellous bone. So cancellous bone is inside the cortical plates surrounded. So cortical bone is, from our pathology and from your general and histology, we know is a thicker plate of bone. So if somewhat we take the advantage of this thicker plate of bone, the tooth movement will slow down. So cortical bone is more resistant to resorption and tooth movement is slowed when a root contacts. So what do we need to do? We just need to torque the roots of the posterior teeth outward towards the cortical plate so as to inhibit their movement. So before starting the major tooth movement, we can torque these teeth so as to minimize the tooth movement. Their movement is known as cortical anchorage. So as I was telling, this is an image of a transpalatal arch. It was given by Goshkarian, so also known as Goshkarian arch. So see, this is a wire component which is connecting one molar from one side to the other as well. Next, as I told, involving the second molars as well, so that our wire extends till then. Next is a image of Nance palatal button or Nance palatal arch. It was again part of image based question of your previous I9 exam. So this is a Nance button which is made up of acrylic, taking the help of palatal mucosa for anchorage support. I hope I am clear. So I'll move ahead to the next classification system which was given by Professor Ravi Nanda, in which he classified into group A, B and C. So this is again a very important classification system. Okay, group A anchorage, group B and group C. This way image and theoretical questions many times the examiners have asked. So group A is maximum anchorage, in which there is not more than 25% of the molar tooth movement. Group B is moderate anchorage, in which there is equal amount of movement of the anchor and the M unit as well, that is 50-50. And group C is low, in which there is 75% movement of the anchor unit. So a better way to understand, because right now it's very clear, in the exam students get confused. So group C is low, means 75% movement of the anchor unit. Now this anchor unit can change. It can be posterior as well, anterior as well, desired or depends upon the type of tooth movement which is desired. Sometimes it occurs is that we extract the teeth so as to mesialize the posterior teeth so as to close the space instead of retracting the anterior teeth. It is also possible that there is crowding or some problem, so that, or we want to make space in the posterior arch so we mesialize the posterior molars. So in this case, the anchor unit becomes the anterior teeth and the movement or M unit becomes the posterior teeth. So the group ABC anchorage changes. So that's why I'm telling you, understand the concept rather than just mugging that it is group ABC. A matlab Saxon anchorage, 25% molar movement. It is always molar. No, it is not always molar. It is the anchor unit. Okay, so this is how it is depicted in the form of diagram as well. Okay, which can come with your image based question. So group A anchorage, 25% movement of this. Group B, equal movement of anterior and posterior anchor and M unit. And group C, more movement of the anchor unit as compared to the M unit. So here A greater than M, A equal to M, and here A is moving more than the M unit. So anchor and movement unit instead of anterior and posterior, because this can change according to the type of movement desired by the orthodontist. Now later on, this classification system was further modified and a group D system was added. So group D is what do you mean by absolute anchorage. That means a situation in which there is 0% movement of A unit, that is 100% anchorage, or 0% movement of A unit. So how do we get absolute anchorage? So absolute anchorage will be gained through the help of skeletal anchorage devices like you just asked, like TADs or mini implants and mini plates. So these things are inserted into the cortical plate, so they can be example of cortical anchorage as well. They are example of skeletal anchorage units, okay, and they can also act as a means of reinforcing. So we are using additional means so as to reinforce our anchorage. So there are certain situations which we cannot afford even 0 mm of movement of certain teeth. Okay, so there we take the help of these things. So coming to the skeletal anchorage or absolute anchorage. So the first example of this is TADs or temporary anchorage devices. So these are like implants but smaller than those. So implants which are used for prosthetic purposes, for replacement of teeth. Here they are not used for prosthetic purposes, hence they are temporary, means during the treatment they are inserted. Once the orthodontic treatment is completed, they are taken out. So in prosthetic implants, they are fixed prosthetic implants. Okay, the material which they are made of is titanium. Here they are not made of titanium, they are made of stainless steel. So they are just inserted for the treatment and taken out. They are not inserted in the empty sockets as well. So they are very different in the make and the sizes. They are much smaller as compared to prosthetic implants. So I am going to discuss about temporary anchorage devices or TADs. So the maximum insertion torque is 5 to 15 Newton per centimeter. Okay, the maximum force which we can exert while inserting them is 380 to 450 grams or 3.75 to 4.5 newtons. And angle of insertion is 60 to 70 degree with respect to the bone present. I'll just explain the method of insertion in a few upcoming slides. Next is this Freeman's anchorage value diagram, a very important diagram. Was recently asked in your November, I think, INI exam last year 2024 only, in which they asked you about it. Based on this, they gave you these values. You need to determine which will be the most desirable anchorage unit, or somewhat similar kind of question was there. Okay, so you don't need to remember all of these anchorage values. These are based on the root surface area or the periodontal surface area given by Freeman. So सबसे ज़्यादा most you need to remember, least you need to remember, and the first lower molar you need to remember. Okay, most is of maxillary first molar, least is of mandibular central incisor, and mandible first molar is 475 gram per mm square, milligram per mm square of root surface area. Next example, a very important example जिसमें students get confused, that is inclined plane. So inclined plane or anterior inclined plane is example of reinforcing the anchorage. So what do we use? Why do we use upper anterior inclined plane for? Lower anterior inclined plane is a example of क्या है? That is Catalan splines used to correct the upper anterior cross bite. Now here I am telling you about upper anterior inclined plane. So why do we use the upper anterior inclined plane? So as to glide the lower jaw forward. So what happens? So this is the upper teeth, this is the palate, okay, and this is the inclined plane, upper anterior inclined plane. So the lower teeth come and they sit or lock inside this anterior inclined plane. So they are glided forward. So lower teeth are attached to the lower jaw or the mandible. Mandible is attached to the TMJ or a temporomandibular joint through the retrodiscal tissue. So that there is stretching of the retractor muscle, which forces the mandible forward against the anterior upper anterior inclined plane. Okay, so this was the desired effect for which we gave the upper anterior inclined plane. What will happen? For every desirable action, there is an undesirable action as well. So the lower jaw is getting mesialized. What will happen? Undesirable, the upper jaw will get distalized, or the upper teeth will get distalized. Okay, and that is why it reinforces our anchorage. Okay, so lower jaw getting mesialized, upper jaw getting distalized. That's why this anterior inclined plane reinforces the anchorage system. Okay, so generally they are given for class 2 correction. Class 2 molar correction, the lower jaw is behind, we just glide it forward, similar to that of twin block. Okay, next, Swed appliance. Swed appliance, in which we inclined plane is given with the incisal capping. This is the image. The incisor teeth are capped like this. The acrylic caps the upper anterior incisor teeth as well. Next is a slide on Tweed's anchorage preparation. They was earlier used. He classified the anchorage system into first degree, second and third degree. You just need to memorize these values. First degree anchorage preparation are those in which the teeth, their aesthetics are good, the ANB is between 0 to 4 degree and there is discrepancies less than 10 mm. So the molars are kept upright and maintained. Second degree, the ANB is more than 4.5 degree. Okay, so the mandibular molar teeth should be tipped till the margin level at the gum level. And third degree, our ANB does not exceed 5 degree, but the discrepancy is more than 10 mm, that is between 14 to 20 degree mm. So the mandibular molars are tipped distally below the gum marginal level from all premolars to the second molars as well. So what is the advantage of tipping these teeth? As I've already told you, cortical anchorage. If we tip these teeth distally, the amount of force which is desired, first the desired force will upright them, then they'll move. Rather than if they are upright, they will start to move forward, okay, quickly. So there is upright teeth, decrease anchorage, distally tipped teeth, more anchorage. So this was a earlier or age-old concept, beginning of the 19th century, when these TADs, these appliances did not came. So earlier what they used to do is they used to tip these posterior teeth behind distally below the gum margin level so as to increase the anchorage value. Okay, so there was an additional step. Now we have leveling, alignment, space closure and finishing detailing. Okay, stages of orthodontic treatment, if you know. Okay, now but earlier there used to be a second step or additional step known as anchorage preparation. So this distal tipping was part of anchorage preparation. So you used to prepare the anchorage unit, then extract the teeth and then correct the proclination of anterior teeth by retracting. Okay, so we're going to have a brief discussion about two things, that is temporary anchorage devices, that is TADs and mini plates. So as I've already told you, TADs are bone screws or devices for anchorage to bring about desired tooth movement. So these are the images. Okay, so there are certain properties of these TADs just similar to that of prosthetic implants. Okay, so first is stability. Stabilities are two types, short term and long term stability. So short term is also known as primary stability. Okay, so the time at which we insert the screw or the initial insertion, the primary stability comes into effect. Okay, so it is determined by the mechanical retention of screw in the bone. Okay, so it is depends upon the bone properties, the engineering design of the screw, and the placement technique. Okay, secondary or long-term stability comes into play. Secondary or long-term stability comes after a few days when through the union or the biological union of the screw with that of the surrounding bone. Okay, so what factors it will depend upon? Up to we have inserted and left it there. So now the implant surface, how the implant surface is. Tent peg anchorage is involved there, sir. Yes, this is the example of tent peg anchorage system. So technically there is no term as tent peg anchorage, first of all, so don't get confused that there is a tent peg anchorage. So what you mean to say is, during when we go for camping or something like that, we used to, what are pegs? Pegs are the screws which we place in the ground, and through this the tent is attached. So these screws are at an inclination like this. So what happens when the wind blows, these screws don't get uprooted directly and blow away our tent. Okay, so this distal tipping is a kind of tent. How do we place the pegs during tent peg? So there is no term as such as tent peg anchorage system. Okay, so it's just a way to understand that what Tweed used to do is distally tipping is the same kind of tent pegs. How do we place them, hammer them in the ground by inclining them away from the wind direction so that they do not get uprooted. Okay, so coming back to secondary stability of temporary anchorage devices, so it depends upon the implant surface, the surrounding bone characteristic, whether it's cortical or cancellous bone, and the bone turnover. So clinical stability is a sum of primary and secondary stability. Okay, so for success of our implants, it is important to minimize the micro movement or the movement of the implant which occurs during the initial few days. That's why the loading of a TAD is not done initially. It is first allowed to get stabilized. But in recent concept, just a add-on thing, this concept has changed, and there is a debate versus immediate versus delayed loading, in which we say that there is no such difference. Okay, if the insertion technique and the technique is proper, the primary stability would take the advantage. So there are biomarker researches which are taken off. Okay, and not the time to discuss it right here. Okay, the markers and all which we covered in the biology of tooth movement. Moving ahead, next are the factors related to the stability of screw. So first is pitch of the screw thread. So what is pitch? Pitch is the distance between the screw serrations. So how close or far apart the threads are, that means. So tight pitch, there is a two terms that is used at tight and loose pitch. Tight means the threads are close, loose means they are apart. So what is the concept? So in dense bone, that is thicker bone, we should have a tight pitch screw. Why? Because most of the screw, okay, so most of the screw resistance to being dislodged comes from contact with the cortical bone and relatively little from the medullary bone. Okay, so cortical bone has the most tendency to dislodge the screw. So here the pitch should be tight so that the surface area increases. Okay, जितने threads ज़्यादा engage कर जाएंगे cortical bone में, that is more better, so that dislodging force of the screw gets. That's why if the designer or the makers of these TADs have a tight pitch on near the head of the screw, that is in this region, and as you can see the pitch becomes loose. or far apart as the screw moves down, because the lower part goes inside the medullary bone and the outer part is near the cortical bone. So here the thread is tight and lower it is loose. So tight pitch means greater contact or surface area, more contact, so less resistance to dislodging force. Next is length of the screw. So a length determines the amount of contact with the cortical bone, okay, not with the medullary bone. So typically it is between 4 to 6 mm. Lastly, it is diameter. Diameter is the thickness. It is approximately 1.3 to 2 mm. Okay. Next important thing is the form of the tip, whether it is self tapping or self threading. Okay, so what happens is, as we advance the screw or place the screw like this, imagine placing a screw inside a wall. What we do, we take the help of a screwdriver, we turn it, and that's how it gets advanced. Similar kind of principle is advocated while placing TADs inside the bone. The only difference is, instead of wall, we are placing it inside a human body, so we need to take care of certain threshold values, certain insertion torque as well, so as to not damage the bone, surrounding bone. If surrounding bone gets damaged, the primary stability is gone, the screw becomes loose quickly. Okay, so coming back to the form of tip, so there are two types of tip, whether it can be thread forming or thread cutting. So what is thread? Thread is the bone. When we turn the screw, the amount, the bone which gets involved, in some thread inside the screw serrations. Okay, so thread cutting will be the one which cuts the front bone and gets advanced. Okay, so what will be the advantage of thread cutting? So how does a thread cutting first of all looks like? So it will have a cutting flute or tip, cutting edge at the tip of the screw. So it will be advantageous in penetration into denser bone. So mostly we want to place the TAD into retromolar area. Okay, so as I've told you, TADs are not something which will always be placed into inside an extraction socket. Sometimes we place it into retromolar, buccal shelf area, zygomatic implants. Okay, their bone is much dense, so there we involve thread cutting. Okay, so example where we place into ramus area, buccal shelf area, zygomatic buttress area, or palate sometimes. Here we involve a thread cutting surface, so that it cuts the denser bone while we place it. Next is thread forming. Thread forming is the one which we place into a less dense bone, supposedly between, most common in the buccal screws, which we place interdentally between two teeth for retraction. Okay, so ease of screw contact and ease of advantage placement as well. Okay, so these both are example of self tapping screw, that is, they create their own threads while they advance. Next broad category is self tapping and self drilling. So what is the difference between self tapping and self drilling? Self drilling, they require a pilot hole. Okay, so in prosthetic implants, certain times we require a pilot hole or a pre-drill before placing. So pilot drill is done so as to remove plas, so that the screw passes through the thicker cortical bone, and then we can just turn it and it goes inside. Okay, so self drilling are the ones which require a pre-drilling pilot hole for placement. Okay, so which self drilling are the one which require a pilot hole for placement. So this is a summary of what I have just told: the screw diameter, the screw length which is 6 mm, where it is 4 to 8. I have told you the range, the diameter. This is a direct picked up table from the textbook of William R. Proctor. Okay, next important thing is direct versus indirect anchorage. So what do you mean by direct and indirect anchorage? So we have less time, so I'll just move ahead thoda sa quickly. If anyone has any doubt, can stop me and I'll explain that. Very important topic. Direct anchorage means in which we take the help of the temporary anchorage or the screw. So in the first image, what we have done is we have placed the tads interdentally between the teeth, and we are retracting the anterior teeth by attaching the screw coil spring directly to it, directly attached. In indirect anchorage, what we do is we paste the screw and we attach the anchorage unit to it, and the retraction or the coil spring is placed from the teeth itself, not from the mini plant in implant. So direct anchorage screw is used directly to retract the protruding teeth, and indirect anchorage when a rigid attachment is placed from the screw to prevent movement of the anterior or from the anchor unit. So this attachment is just placed with the help of composite attached to it, and the teeth are retracted. Next I'll just discuss in a short summary point of view the surgical procedure for insertion of TAT. So first is perforating stage 1, second is perforating stage 2, third is guiding stage, and fourth is finishing stage. So in perforating stage 1, what we do is we approach the cortical bone. Outside is the cortical bone. Supposedly we intend to place it interdentally between the first molar and the second premolar, that is between the 5 and 6. We approach it perpendicular to the cortical bone first to avoid slippage during. So as I have told you, cortical bone is thick. We need to approach it perpendicular so that we can अगर हम slanting introduce करेंगे थोड़ा भी, so cortical bone का जो distance which we need to cover will become more, and it will become more difficult to penetrate it. So we need to approach it first perpendicular to the cortical bone so that we penetrate it quickly. Okay, next stage 2, perforating stage 2. Now in this stage, after we have penetrated some distance inside the cortical, we angulate the drill or angulate the driver here, so that maximum amount of surface area or engagement area of the bone is taken of the cancellous bone or the medullary bone. So here proper insertion angle I have told you 60 to 70 degree where we then insert so as to take maximum advantage of the surface area. So here proper insertion angle is done. Next is guiding stage. Now here we just drill it and advance the screw inside to 2/3 of full length. And finishing stage, the rotation should be applied without any vertical force to maximize cortical bone failure or withdrawal support. Okay, so last is finishing stage. So these are the 4 basic stage. So they are just covered them in a brief. Okay, point. Next are the mini plates. So as implants, mini plates are also used for anchorage, skeletal anchorage system. So they have 2 components. One is a plate component and a connector component. Plate is the one which goes inside the inside the bone, and it is contoured to the surface of the bone, and connector which penetrates outside the bone. So that it is in the form of this. Like this. So this is the plate part. It can be 1 screw, 2 screw, 3 screw as well, and this is the connector part. So what are the determinants? Like in implants, in plates, what are the determinants of stability? First is the number of screws with which the plate is attached. Determine the bone thickness and density in that area. Next is the age of the patient. So the bone level or the thickness should have been matured enough for us to have a good retention of the screw, so that approximately 11 years of age is taken before we intend for such treatment to be taken. And lastly, the location where we place. It can be in the base of the zygomatic arch in the maxilla, buccal shelf of the bone of the mandible, or anterior surface of the ramus, where the bone thickness is more. So a question, pitting of the bodily movement of teeth against tipping movement is called as. So as I've already told you, certain keywords are important. So this is a previous year question of May 2005 only. Pitting of bodily movement of teeth against tipping movement means bodily movement ko we have stopped against the tipping is called as. Options are stationary, reciprocal, reinforced and curved. Now they haven't given you the first simple anchorage as an option, so it becomes easier for you to say stationary. Dono words tipping and bodily movement were there. So as I've told you in the beginning, you need to understand the concept behind this. Next, one of the greatest advantage of using external anchorage is that, okay, so more force can be applied. No, anchorage mein you don't need to apply force, we need to preserve it. Direct reciprocal action on the opposing arch omits the posterior movement of teeth in bunch march without adversely disturbing the opposite arch. Next, resistance units of equal size pulling against each other in example of which type of anchorage. So equal size, again keyword, हमेशा कीवर्ड पे ध्यान देना, then only you can answer it. So it's example of reciprocal anchorage. Okay, so that's it from my side. If anyone has any doubt, you can tag me, you can reach us on a WhatsApp and Facebook club and we will be able to answer you. Okay, anyone has any doubt? Next session on cephalometrics, please. Okay, I have kept it. I think next to next is on cephalometrics, so it will be taken care of. Okay, anything else? Okay, otherwise I'll close it the session. I've already taken time outside what is permitted for me. Okay, anyone has any question, just tag me. If I've remained interrupted intermittent forces of jack screw, I'll explain it. Okay, if you can just tag me on the club, I'll be able to help you out there. Okay, sorry I did not take anything related to anchorage. Please do tag it. I need to close it. I am getting